We're going to talk about the Achilles tendon. It's an interesting topic because if we look at the way the human beings evolved for upright bipedal ambulation, humans develop specialized structures, and one of them is the Achilles tendon. It's unique in humans compared to other walking or ambulating primates in multiple areas. But what's interesting is these specialized structures unique to humans seem to be those same structures most vulnerable to injury. And podiatrists and lower extremity clinicians are constantly faced with pathologies of the Achilles, the plantar fascia, and the most common injury in sport, the lateral ankle sprain. We're going to talk about two of these pathologies tonight as we explore offloading strategies. In terms of the Achilles, these are two studies that show Achilles tendinopathy, not ruptures, just Achilles tendinopathy, are either number one or number two in prevalence, depending on what type of running population we survey. So it's right at the top of the list in almost every study we look at. There are many conditions where we're trying to offload the Achilles from specific injuries, such as the most severe, the acute Achilles tendon rupture, the more chronic mid-substance Achilles tendinopathy, the insertional Achilles tendinopathy, and then indirectly the plantar fasciopathy, which is directly related to the Achilles. You know, if you read advice that doctors give patients on the internet or in chat rooms or in books, it seems to be the most popular intervention when someone's got a problem with their Achilles is they're told to put a heel lift in their shoe. And heel lifts are not only used to treat the Achilles, but often used to treat unequal limb length. Maybe indirectly try to address equinus and offload the pull of the Achilles if the equinus deformity is thought to be creating other pathologies, and often used to indirectly release strain on the plantar fascia. So it's really been kind of a long-standing belief that a heel lift will decrease tensile load on the Achilles, and in this particular article actually increase healing of the degenerate tendon. But this study didn't actually measure the effect of a heel lift. It just propagated the anecdotal evidence that's been passed down from several generations. But there are many misunderstood aspects of using heel lifts clinically. And we're going to explore both of these. The first is the anticipated mechanical effect of putting a heel lift inside of a shoe, and then the active physiologic response when we either put a heel lift in the shoe or when a patient moves into elevated heel footwear. Surprisingly, as I'm going to show you in this webinar, heel lifts, when they're placed in the shoe, actually increase pressure under the calcaneus. They may cause increased calf muscle activity and actually increase tensile strain in the Achilles. They can also increase strain in the plantar fascia. And as I'm also going to show you that heel lifts of up to 1 centimeter will not plantar flex the ankle and cannot predictably decrease tensile strain in the Achilles. So the first interesting factor about heel lifts is the fact that they increase pressure under the heel by over 50%. And so I've seen articles or writings of other clinicians using a heel lift to theoretically decrease pressure under the heel. And the only way you can really decrease pressure under the heel is to put the patient in an elevated heel shoe, but not put a heel lift in the shoe. When we look at studies of effects on Achilles tendon loading, we have to keep in mind that load has certain aspects, the magnitude or the peak load applied to the Achilles. Other clinicians think the rate of loading is important in terms of damaging and rehabilitating the Achilles. The timing of the load, is it appropriate during the walking or running gait cycle? And then considering the neuromuscular response of the patient and the firing of the muscle in response to the heel lift may throw off all of those other factors. So, two studies that were published several years ago, actually quite a while ago, but have not been really replicated. They show us that when we put up to 1 centimeter heel lifts inside of a shoe of a runner, we don't see any reduction of magnitude of Achilles tendon force, but we do see decreased rate of loading. And we're not sure if that's a direct mechanical effect or perhaps a physiologic effect. But more importantly, both of these studies show that it's a very individual response. Some runners reacted favorably to the heel lift in terms of anticipated reduction of load in the Achilles. Others had actually increased load in the Achilles when a heel lift was applied. And this brings out and reinforces what many of us have learned in clinical practice, where we see variable response of runners to things we put inside of their shoes. When we look at running shoes alone and effects on Achilles tendon loading, there have been some interesting studies recently. And these definitely demonstrate not a mechanical response, but a physiologic response. This study that got a lot of attention 9 years ago, published by Scott Waring and his group in Australia, they compared subjects running barefoot to running in a 10 millimeter heel elevation standard running shoe, and they measured load of the Achilles with an acoustic velocity device. Surprisingly, the shoe condition increased loading of the Achilles compared to running barefoot. After a lot of criticism, they came back and did another study on the same subjects, and this time added a 12 millimeter lift to the standard 10 millimeter heel stack height running shoe. And indeed, when the 12 millimeter lift was combined in the running shoe, there was a significant reduction of tensile load compared to the non-lift condition. All of this probably demonstrates some type of physiologic response to the mechanics of the foot hitting the ground and the activation of muscles. But either way, the authors wanted to point out that reducing load of the Achilles is not necessarily a desired effect, specifically when we're treating athletes with Achilles tendinopathy, and we actually want to increase eccentric loading of the tendon to facilitate healing. We're going to talk about that more later in this webinar. Now, what's interesting is when we place a subject in an elevated or a so-called high heel shoe, we see much different effects than with that same individual wearing a low heel running shoe and a 1 centimeter heel lift. When we put a patient in a high heel shoe, it decreases pressure under the calcaneus and shifts pressure to the forefoot. But it also creates some instability, primarily with inversion of the ankle and hindfoot. This series of studies verified what I just showed you, a shift of pressure away from the rear foot to the forefoot, and increased pressure and loading of the first metatarsal, which would not be good for a patient with a pre-existing bunion deformity. But what's more concerning, when we recommend wearing higher heels to relieve tension in the Achilles, it does increase calf muscle activity, which may have reciprocal results of increased strain in the Achilles itself. A couple of references here that verify what I just said. And an interesting study using EMG activity showed significant increased activity, particularly the medial gastrocnemius, when patients wore elevated heel shoes. So this is a negative effect if the purpose of recommending higher heel shoes is strictly to offload the Achilles. We're going to talk a little bit about Achilles tendon ruptures. This is an important public health issue because, as most of us have observed, we're seeing a marked increase of Achilles tendon ruptures in all patient populations. This study showed a near doubling of incidence in a 10-year period between 1987 and 1999, and that's actually increased more in the past 2 decades. We've also seen a growing trend worldwide. This really started in Europe, but it's now spread to the United States, where the preference is to perform non-surgical management of the acute Achilles tendon rupture. This is because of accumulated evidence showing that there's really an insignificant difference in the functional recovery of a patient, whether they have non-operative or surgical repair of the Achilles tendon. A more recent systematic review and meta-analysis of a large body of literature on this subject concluded that there is no statistically significant difference in the functional outcome of patients treated operatively or non-operatively after Achilles tendon rupture. They have similar functional outcome. The only difference is there is a slightly increased but statistically significant increased risk of re-rupture in the surgically treated group when we look at all of these studies combined. There are some studies that contradict that conclusion. Notwithstanding whether patient undergoes surgery or is treated non-operatively, the standard of care includes immobilization of the ankle in an equinus position for some unspecified period of time. The reason clinicians have traditionally recommended immobilization in equinus is to presumably reduce the gap between the ends of the ruptured Achilles tendon and to reduce tensile strain on the Achilles during the healing process. On the first factor of the gap between the ruptured end of the tendons, this important paper published in 2016, or I'm sorry, in 2016 in JBJS, showed that in a patient with a ruptured Achilles, the average distance or gap between the ruptured Achilles in this group was 12 millimeters. But once the ankle was positioned in the maximal equinus, the 12 millimeter gap reduced by half to 5 millimeters. And even with subsequent flexion of the knee to remove all tension of the gastroc, there was only a slight reduction of the gap between 5 to 2 millimeters. The essential change occurred when plantar flexing the ankle into full equinus, reducing the gap between the torn ends of the Achilles. The preferred method pretty much worldwide of immobilizing the ankle in an equinus position after Achilles tendon rupture is the use of removable walking boots with a stack of wedges placed under the heel in the bottom of the boot. Most of these wedge systems are graduated and are stacked with either half-inch to three-quarter-inch increments so that the clinician can gradually reduce the height of the heel lift during the healing process. But what's interesting is we've just recently discovered that placing these heel lifts inside a walking boot or a shoe do not always plantar flex the ankle to reduce strain on the injured Achilles tendon. This was an important study that was published in 2017 by Ellison and his group in England. And it really opened a lot of eyes of surgeons and other clinicians treating Achilles tendon ruptures. They took a group of patients, all with ruptured Achilles tendons, and they treated them with 3 different offloading strategies after the rupture. One strategy was to use an equinus cast in full equinus. Another intervention is an adjustable calibrated ankle motion boot. And finally, a fixed 90-degree boot with the heel wedges I showed you previously. So this is the maximal equinus cast, which in this study was left on the patient for 2 weeks, and then they were progressed into one of the 2 orthoses I just mentioned. One of the orthoses is the adjustable platform cam boot, in this case, the Vacoped boot, which is very popular in Europe and can be calibrated and plantar flexed to 30 degrees. The other choice was to put them in a fixed Oser walking boot with a stack of heel wedges. In this case, they were from DJO, Donjoy Orthopedic. And these wedges come in 3/4-inch increments stacked up on top of each other to a total height of up to 4 inches. The researchers took a lateral weight-bearing x-ray of the patient And they compared the 4 conditions. A would be a control subject without a rupture, and this is the normal alignment of the tibia to the talus. When the patients were placed in a plantar flexed equinus cast, we can see the marked change of alignment of the talus as the ankle joint moves into equinus. That marked position of equinus is reproduced fairly accurately in the Vacoped adjustable cam boot. But in the fixed walking boot with the stack of wedges, we see that there's no plantar flexion of the talus. Instead, we see marked plantar flexion of the forefoot on the rear foot, but the ankle joint itself and hence the Achilles tendon tension are unchanged. So if we look at the talotarsal, the tibiotalar angle, the large angle is preferable. It means a large amount of equinus, 56 degrees in the cast. The walking boot only achieved half of that with the wedges. The adjustable boot achieved a pretty similar position as the total equinus cast. But what's interesting is what they observed in these platform heel lifts. The platform lift, which are popular in orthopedic companies for comfort to provide a stable platform under the heel, actually encourage and allow plantar flexion of the forefoot on the calcaneus, thus eliminating any ankle joint equinus and instead creating forefoot equinus. So to keep this patient's foot flat in the boot, all they had to do was plantar flex their forefoot on the rear foot, but the ankle joint did not plantar flex. Hence, the tension in the Achilles tendon is identical to that when they wear no heel lift whatsoever. This same result could be expected from a short heel lift that supports only the calcaneus and allows the rear foot joints, the mid-tarsal joint, and transverse tarsal metatarsal joints to plantar flex. There will be no repositioning of the ankle into equinus. A fully tapered wedge from heel to ball to the metatarsals will tilt the entire foot into equinus in a similar way that the adjustable cam boot would, or what simply happens when a patient wears a high-heeled shoe. That's a desirable plantar flex position of the foot and ankle. This was borne out in a subsequent study recently published last year, similar to the study I just showed you. This group of researchers studied the effect of the platform heel lift, which was used in the previous study, to the fully tapered heel lift. And the results are quite interesting. This again is the same platform lift used in study number 2. And this is the true tapered heel lift. This is provided by a company in the United States called Breg. I've seen other companies that also offer the fully tapered without the platform or the plateau. This study also compared to the Vacoped boot and an equinus cast. That's right. So here's what they used as a measurement. This is interesting. They didn't draw an angular measurement. They actually plantar flexed the ankle and they measured the distance from the uppermost point of the calcaneal insertion of the Achilles to the ankle mortise. They drew a line across the distal margins of the tibia, and then they dropped a perpendicular down to the insertion of the Achilles. And as that distance increased, down in this photo, the assumption is there's an increase in tensile loading of the Achilles. So here's the equinus cast. And we see that there is a narrow margin here of 15 millimeters. We can achieve that same thing with a stack of tapered heel lifts, 13 millimeters. We can also achieve close to that with the Vacoped boot. But when we put a heel lift with a platform, that's WWP, we see a very minimal repositioning of the ankle into equinus. The data is shown here. So the equinus cast achieves this AARD of 11 millimeters, we want to see a small number here. This numbers are all big with 1, 2, or 3 wedges. That's the platform heel lift. This is the wedged inclined heel lifts without a platform. They don't really begin to achieve a significant narrowing of the distance or Aquinas positioning until we use 2 and more importantly 3 wedges. And we really don't see the Vacoped boot get to that Aquinas cast position in terms of the skeletal positioning until we get to about a 30 degree plantar flexion. So these lower levels of plantar flexion of the Vacoped boot didn't really approximate the necessary Aquinas positioning in this study. So what's interesting is if you use these heel platform wedges, and here's 1 wedge, 2 wedge, and 3 wedges, the Aquinas positioning of the heel bone really doesn't change even when you use up to 3 wedges. It stays relatively the same because in each case, the forefoot just simply plantar flexes off of the wedge. If you use a tapered wedge, you will get ankle plantar flexion, but you've got to use at least 3 wedges. And in this Donjoy the Bragg wedge system, that's 3/4 inch of each particular lift. So that's quite a significant lift. So heel wedges with platform do not place the foot in desired Aquinas. However, if we use heel wedges that are inclined, we can get enough Aquinas positioning if we use a total of 3 wedges. We need at least 20 millimeters of elevation when we use heel wedges without a platform before we see significant change, and we need 30 degrees of plantar flexion in the Vacoped boot. A third study was also performed in the UK. This case, they used an Aquinas cast that was applied with the foot hanging in gravity. So they didn't force the ankle into Aquinas, they just did what's called a gravity-dependent cast. And then they wanted to compare that to the use of heel lifts inside of a boot, similar to the previous study you saw. But in this case, they used 2 different kinds of wedges, but they mixed them up and they considered them similar, but they aren't similar. The Oser wedges they used in this study have a platform, and therefore they're going to give a totally different result than the Bragg wedges, which don't have a platform. But unfortunately, in this study, they mixed the wedges together on all patients who received a boot. And sure enough, the patients who received a boot did not get significant reduction of their Aquinas position, as the data showed. So basically kind of reproduced what we saw in the other study, but unfortunately condemned the use of heel lifts in general, when really some of these lifts probably performed okay if they were a pure incline. So what we've learned from this research is we need a full-length tapered wedge without a platform, and it should extend all the way to the metatarsal heads. If we use a platform, we're not going to allow ankle plantar flexion, only midfoot plantar flexion. Same with a very short heel lift. Tapered wedges, if they're used, must extend to the end of the foot plate of the boot, or at least to the end of the metatarsals. And we need 20 millimeters of lift before we begin to see the ankle joint actually plantar flex with the tapered wedges. Now, to keep in mind, these studies just measured skeletal position with X-ray. They didn't really measure Achilles strain or calf muscle activity, which could totally be distorted by physiologic response of the patient. So we have to observe the results of these studies carefully. Finally, the Aquinas positioning of the foot after an Achilles tendon rupture really may be important only in those patients being non-operatively, because gap size of the rupture is a critical factor when you're not going to surgically sew those 2 ends of the tendon together. This study was a prospective study of patients who received surgery in one group and functional rehabilitation or non-surgical intervention in another group. They compared the surgical patients to the patients treated non-surgically. And they found that the patients who had bad results in the non-surgical group were those who had a gap size greater than 5 millimeters with ultrasound examination with the ankle in full plantar flexion. In other words, the gap size really did dictate ultimately what the overall outcome of the non-operative treatment was. In active younger patients, if there's a gap size greater than 5 millimeters, they did not do well. And in non-physically active older patients, a gap size of greater than 10 millimeters predicted a poor outcome. So keeping that gap size down with Aquinas positioning probably is important in those patients who are being treated non-surgically for an Achilles tendon rupture. I think this is a really good protocol that I saw published in JBJS about 4 or 5 years ago. And it basically kind of used tendon gap and age combined to determine which patients would do well following Achilles tendon rupture treated operatively versus non-operatively. And in general, if a patient is under the age of 50 and they have a tendon gap greater than 1 centimeter with the ankle in Aquinas, they really should have surgery. If they've had a delay in diagnosis greater than 2 weeks, they will do better with surgery. However, patients over the age of 50 who have good tendon apposition, which is really 5 millimeters or less, and they're diagnosed within a week of injury, they probably will do fine with non-operative treatment. But I think those patients really do need to be kept in a plantar flex position to reduce the risk of tendon gap increasing. The real question is, what is the protocol for doing this? And is there a gold standard when we treat these patients non-operatively for ruptured Achilles? And it's very interesting. There's no agreement at all in the literature or worldwide as far as the proper protocol of managing these patients non-surgically or even surgically in terms of the immobilization and the positioning of the foot and ankle during the recovery period. But we have to keep in mind that Achilles tendon rupture, and when we keep patients in a severe Aquinas position, especially non-weight bearing, will not adequately restore functional length and power to the Achilles and the muscle. The problem when we position a patient in Aquinas too long is that it puts slack into the tendon, and this immediately causes a retroactive reduced activation and activity of the gastrocnemius. When we do surgery on patients and reoppose the ends of the tendon, we really want to encourage healing by putting gradual load on the Achilles, not slack in the tendon. And we want to increase load during the recovery period. This was a good prospective study comparing patients who were placed not in Aquinas versus those in Aquinas after surgical repair of the ruptured Achilles tendon. And indeed, the patients who were put in a neutral position and allowed to bear weight after repair had less muscle atrophy than those who were immobilized in an Aquinas position. There's getting to be more and more evidence that these patients can ambulate weight bearing early after surgical repair, and that the foot does not have to be placed in Aquinas, because Aquinas positioning can actually lead to detrimental healing. There's reduced calf circumference and reduced calf muscle strength with prolonged Aquinas positioning. Laboratory studies verify the same kind of atrophy with immobilization. These are other studies warning of atrophy with a Aquinas positioning and prolonged immobilization. And as most of you know, the type of collagen repair and the rate of collagen repair is greatly accelerated with progressive loading of the injured tendon. So a recent study by another group in the UK verified the fact that there's no evidence of re-rupture of an injured Achilles when we allow patients to bear weight early after an acute Achilles tendon rupture. And there appears to be no difference in the surgical groups of whether those patients ambulate plantar flex versus dorsiflex. Now, I haven't seen a study that compared the non-surgical groups, plantar flex versus dorsiflex, because it seems that most of the studies I've seen, they're prudent and being very cautious with the non-operative patients being placed in Aquinas at least for several weeks after the acute rupture. But in the surgical studies, we're seeing more and more patients being placed in immediate weight-bearing ankle in neutral position rather than in Aquinas position. So to summarize my view of the research thus far, with non-operative management, we are very concerned about gap size and a positioning in Aquinas. But with surgical repair, there's more and more evidence to avoid Aquinas positioning and allow immediate weight bearing with graduated loading. So if we do want to reduce gap size, we have to plantar flex the foot on the leg. But we don't know really what compensatory muscle activity might occur when we do this. There is an interesting study about what happens when you put them in one of these adjustable cam boots that forces the patient to walk on the front of the boot only. Interesting study done in Sweden, and they put an actual strain gauge within the Achilles itself of subjects, and they had them walk in a plantar flex boot versus barefoot. And believe it or not, when they walked in the plantar flex boot, it increased the Achilles tension to the same level as when they walked barefoot. And what this showed was an increased physiologic response to the precarious position of the patients walking on this extreme plantar flex boot that was not flat on the ground. So this really justifies either putting the patient in a standard 90-degree boot with graduated heel wedges, or consider using a boot like this, which keeps the foot plate flat on the ground, but allows you to incrementally plantar flex the ankle within the boot and adjusting the tibia to foot angle. What I also find is interesting is the emergence of use of carbon fiber AFOs in the management, not only of Achilles problems, but more importantly, Achilles tendon ruptures. Rebecca Kearney and her team have been studying this, and this was an interesting gait study done with both EMG and motion capture, comparing how patients walk in a standard walking boot to a carbon fiber AFO brace with graduated heel wedges. Now, in this study, they were actually healthy subjects, but the findings are interesting, and we can assume they extrapolate over to injured subjects. So patients in walking boots, according to Kearney's study, when they had heel lifts, they had the expected increased pressure under the heel, and they also showed gait disturbances with a standard walking boot. These negative changes in gait included decreased time in terminal stance and in pre-swing, a decreased push-off. This accounts for the development of pain in the hips and knees reported by patients who are immobilized in stiff, restricted walking boots. In this same study, though, when the patients were placed in a carbon fiber AFO brace with a 1-inch heel raise protecting the Achilles, they walked with a normal gait. The author stated this carbon fiber AFO system could lead to accelerated return to function and avoid the effects of disuse atrophy of the calf musculature, and in addition did not show abnormal dorsiflexion of the foot, which might overload the Achilles. So this is an interesting concept that we tried to carry forth with the development of our AeroSpring brace systems, particularly for offloading the Achilles. Carbon fiber AFOs have become more and more popular in the orthotics industry. And multiple research has unveiled the way these AFO braces function throughout the walking gait cycle. During swing phase, they maintain the ankle in a neutral position. So that can be desirable in some cases of Achilles tendon injury. They facilitate heel strike and help facilitate the first rocker. They control tibial progression during the second rocker and limit excessive ankle joint dorsiflexion and loading of the Achilles. They also store energy during the second rocker, which during the third rocker assists in push-off with elastic recoil. Another study showed how carbon fiber AFOs enhance push-off during terminal stance and pre-swing. Compared to polypropylene plastic AFOs, and by the way, walking boots are basically plastic AFOs, carbon fiber braces show increased ankle joint plantar flexion power, increased plantar flexion ankle moment. This is all due to storage of elastic energy. They improve walking speed and stride length, and they decrease energy cost compared to plastic AFOs. So these are all very positive things. But this reduced muscular activity and artificial ankle push-off can be very desirable for patients recovering from an Achilles tendon rupture, or perhaps during the early phase of recovery from Achilles tendinopathy. So we see these changes during the first and second rocker, but it's really this reduced demand for ankle joint muscular contraction that can maybe be an enhancement for the patient during recovery. From the research, at least from Rebecca Kearney, the best system seems to be a carbon fiber AFO brace inside of a lace-up shoe with only a 1-inch heel raise necessary to prevent excessive dorsiflexion. A 1-inch heel raise is about 20 millimeters, and that can be pretty well tolerated on top of a carbon fiber brace inside of an AFO shoe. Our system uses a custom functional foot orthosis combined with the heel wedge and the carbon fiber AFO brace, and I'll explain the rationale for that in just a moment. And it really boils down to what we've learned about offloading the plantar fascia and combining heel lifts with foot orthotic therapy. We do know anecdotally patients with chronic plantar heel pain, i.e. plantar fasciitis, report that they have less pain when they wear higher heel shoes. And we look back and we try to, or perhaps when they wear a heel lift. And we look at really now what we understand are the primary mechanical mechanisms for loading the plantar fascia, and we want to figure out why a heel lift or heel raise would help that. One is we know that the medial longitudinal arch can load the plantar fascia through the truss mechanism. The Achilles tendon is a loading force, and more recently we've discovered that extension of the first MTPJ is a loading force. The truss, or the medial longitudinal arch, is the least important loading factor of the plantar fascia according to studies. The Achilles tendon has a much more significant load on the insertion of the plantar fascia than does the arch deformation. The Achilles tendon has actually a 2 times greater straining rate than body weight alone on the foot. Besides the Achilles tendon, the windlass, the extension of the great toe during the push-off phase of gait, also places significant strain on the plantar fascia. Now, placing a simple heel lift under the shoe, we know increases pressure under the calcaneus, which is not desirable when the calcaneus is already inflamed and painful. But it also may strain the truss structure of the foot by creating pressure at point number 2 here, which according to the truss mechanism would then increase tensile loading due to lowering of the calcaneal inclination angle. That's just a theoretical perception, but it's verified by some other studies. I'll get back to that in a minute. But this recent insight into the windlass is quite interesting. And as the hallux dorsiflexes, tension develops in the plantar aponeurosis. And this study by Carlson back in 2000 showed that while the Achilles does put 314 newtons of tensile force on the plantar fascia, dorsiflexion of the toes actually creates a greater 511 newtons of force. So the plantar fascia is influenced 84% by dorsiflexion of the digits and only 15% by Achilles tendon force. Another study showing that dorsiflexion of the digits contributed 66% of the strain to the plantar fascia, while the Achilles tendon accounted for only 33%. So this dorsiflexion of the digits is a big loader of the plantar fascia. And how can we reduce that? Well, we've learned that rocker sole footwear, such as the Hoka, the super shoes with very dense rocker sole, midsole designs, can reduce dorsiflexion of the hallux, and from this study, potentially reduce strain in the plantar fascia. This was actually a clinical study showing that when patients were placed in Hoka type footwear, they not only had reduced pain, but a faster overall recovery and favorable results with gait studies on the effect of the rocker sole shoes. And therefore, it appears that the combination of the rocker sole shoes with custom foot orthoses in this study had immediate beneficial therapeutic results. Another way we can reduce hallux dorsiflexion is with carbon fiber spring plates. Interesting study in Australia at La Trobe University, this time looking at first metatarsophalangeal joint osteoarthritis. Significant reduction of hallux dorsiflexion with the insertion of a carbon foot plate. Another study at the University of Calgary, placing a carbon foot plate in a Nike Free, significant reduction of first MTP dorsiflexion. The summary of these studies showed that there's decreased loading of the first MTPJ with carbon fiber foot plates, which could decrease loading of the plantar fascia, and also, interestingly, decrease loading or strain on the medial longitudinal arch, which indirectly would decrease strain on the plantar fascia. So a carbon fiber brace has a carbon fiber foot plate. So we can anticipate that the carbon fiber foot plate of the brace would also achieve these two factors. Back to heel elevation, not to downplay the role of the Achilles, because we do know that when we elevate the foot inside of a high heel shoe, it does decrease strain on the plantar fascia. And this study, at least a cadaver study, showed it decreased strain twofold. This was a computerized study, again verifying that moving up to a 2-inch heel shoe significantly decreased loading of the plantar fascia. But this is elevating the heel of the footwear, not putting a heel lift in the shoe. So when we place a patient in a higher heel shoe, we not only decrease loading of the Achilles, but we shift weight pressure off of the heel to the forefoot, which in the case of plantar fasciitis would be a favorable response, at least in terms of pain. It's interesting, though, when you get to too high of a heel, there's actually a increased amount of strain in the Achilles. So we don't want to go too high. The recommendation is about 2 inches, but not anything more than 3 inches. Now, when we put a heel lift in the shoe, we know it increases pressure under the calcaneus. But if we put a heel lift and combine it with an orthosis, it doesn't increase pressure under the calcaneus. Why? Because the orthosis diverts pressure to the midfoot or to the arch. So if we can spread that pressure out under the arch, we won't increase pressure under the heel, and we may facilitate offloading the plantar fascia according to the truss mechanism. So contouring to the arch while elevating the heel can be desirable, particularly with plantar fascia offloading. This was actually shown in an interesting study over 20 years ago by Kogler, who used cadaver models, and he experimentally placed either blocks of foam or contoured platforms under the foot of the cadaver at elevated various elevations, and he measured strain in the plantar fascia. Interestingly, he found when he put just a square block underneath the heel of the cadaver, there was no difference in plantar fascia strain. But when he put a contoured platform that molded under the arch of the foot, the higher he elevated the heel, the more there was reduction of strain. This probably has to do more with the truss arch mechanism than the Achilles, because unfortunately in this study, Kogler did not put any tension on the Achilles. And therefore, without tensioning the Achilles, we wouldn't know the indirect effects of elevating the heel and reducing strain on the Achilles. But at least we do know that a elevated heel shoe that molds or follows the shank profile of the arch will decrease strain in the plantar fascia. A block of foam directly under the heel actually increased strain under the plantar fascia for reasons I showed you just previously. This will increase strain in the plantar fascia, probably because it increases pressure here, decreases pressure here, and leaves the arch unsuspected off of the ground. So this would not be a good scenario for somebody with plantar heel pain, plantar fasciitis. Even the extended wedge without contouring to the arch, at least in terms of the plantar fascia, while this may tilt the ankle into equinus, the exposure of the midfoot would increase strain of the plantar fascia in some patients, according to Kogler. It's interesting, the platform heel wedge, which allows the forefoot to plantar flex, would actually be an ideal system, in my opinion, to reduce loading of the plantar fascia. It doesn't plantar flex the ankle as we showed you earlier, but it definitely plantar flex the forefoot on the rear foot, which in my mind would directly reduce tensile strain on the plantar fascia. You could also get the same effect if you used a custom molded foot orthosis. And in this case, if you applied a heel lift to the orthosis, the entire plate would plantar flex the foot inside of the shoe and not expose the arch to increase loads of the plantar fascia, theoretically. So combining a heel wedge with a custom foot orthosis would help reduce pressure under the calcaneus and the forefoot, and it would allow us to plantar flex the entire foot and reduce strain on the Achilles. And that would be desirable if we're trying to treat chronic plantar heel pain and, of course, Achilles strain. So the ideal system to offload the plantar fascia would be a system that reduced tensile strain in the Achilles, reduced extension of the MTPs, and enhanced stability of the medial longitudinal arch. And that really is what we did when we designed the plantar fascia offloading system. Very similar to the Achilles system, but this one mandates the use of a custom foot orthotic with the heel lift, whereas the Achilles tendon system does not. So I'm going to just finish with some coding stuff real quick, and then we're going to take questions because I'm almost out of time. Everybody always wants to know if they're going to get paid for these systems. So I'm happy to show you that you actually could. Here we go from the current slide. Okay, so as I mentioned, we combine, depends on which system. For the Achilles, you don't necessarily have to get the foot orthoses. For the plantar fascia system, we do recommend the foot orthoses, but the other two components are the carbon fiber brace and the graduated heel wedges. We actually have 4 systems: an Achilles offloading, plantar fascia offloading, a drop foot stability system, a midfoot offloading system, and then we're introducing shortly a diabetic Lisfranc forefoot amputation system. You can order the AeroSpring brace as ordered according to shoe size because the carbon fiber brace is not custom. The foot orthoses do require impressions, casting, or scanning. The heel wedges are according to practitioner preference. All of the ordering is done through an authorized Ritchie brace distributor, which you can find available on our website. They will offer you the prescription form, and you simply pick which system you want and which heel wedges you want. You can be reimbursed for the carbon fiber brace using code L1932. The reimbursement ranges from $800 to $1,000. The custom foot orthoses are reimbursed according to carrier. They're not covered by Medicare. When you bill for the system, we always recommend billing for the pathology and the deformity. In terms of Achilles problems, we bill for either tendinopathy, tendon rupture, or with surgical repair. We can also bill for the plantar fasciitis if that's appropriate. And then we should always bill for list a deformity under the diagnosis codes. In most cases, the equinus deformity is what justifies the use of the carbon fiber brace, whether it's bilateral or unilateral. But in some cases, you may justify the use of the brace due to other deformities, such as significant varus or valgus position of the hindfoot or ankle. The reimbursement for the system, as I just showed you, if the foot orthotics are covered under a private insurance, you can get a total reimbursement of up to $1,200. If you simply use aren't reimbursed for the foot orthotics, you can still get a reimbursement that's handsome enough to offset the cost of the system, which is $600. You can almost make a $600 profit from the overall system. So that's a real favorable thing. More importantly, we get good results when we use this system because we're using the science to apply to the various aspects of it. In conclusion, we've learned from research that higher heel shoes do cause a neuromuscular response that could increase contractile activity of the calf musculature. Heel lifts do not predictably reduce strain in the Achilles tendon, but they may reduce the rate of loading of the tendon in runners. Heel lifts will increase pressure under the calcaneus and can increase strain in the plantar fascia. Heel wedges with a plateau will not position the ankle into equinus. If offloading the Achilles is your goal, that type of wedge would not be desirable. Optimal position of the foot and ankle into equinus is achieved with an adjustable cam boot or a full-length wedge combined with foot orthosis and or a carbon fiber brace. Thank you very much. I did run a little bit over. Hopefully we still have people on board and there's questions. So I'm gonna open this back up. I don't know, Sarah, do you want to read the questions?
Yes, I am coming back on here. Where am I? Can you see me?
Yeah, I can see you.
I don't know, my lighting's all messed up and I switched my view, so just a sec. I don't know why I can't see myself, but if you can see me, I believe you. I hope I look so. All right, yes, I can feel these for you. All right, the very first question we have, how is a half heel lift different than a shoe with a half heel or heel that is half an inch higher than the other side? Or I'm sorry, I'm going to start over. How is a half-inch heel lift different than a shoe with a half-inch heel or a heel that is a half-inch higher than other shoe?
Yeah, I always leave my slides up because it helps me show that. So it really boils down to this. A heel lift lifts the heel off of the bottom of the shoe or the supportive surface. When this same foot is placed in a high heel shoe, the heel sits in the bottom of the shoe, but the entire shoe is lifted off the ground by the heel of the shoe itself. Does that make sense? So in one scenario, the heel is lifted out of the bottom of the shoe, and in the other scenario, the heel remains in the bottom of the shoe.
Okay. we'll ask, if that doesn't make
Okay,
sense, feel
okay,
free
and
to
I think I
chime
know
in.
why they asked the question. So they
Yeah.
want to know, how would that change the Achilles tendon tension? Well, like I said, in this scenario, this doesn't plantar flex the ankle because the forefoot just plantar flexes off this short heel lift. When you're in a high heel shoe, the entire shoe is tilted to the ground and the ankle will predictably plantar flex.
Should the wedge go under the met heads or end just before?
I think they should end just before the met heads.
Okay. Because the orthotic is attached to a brace, is it now covered by insurance?
Yeah, I always get that question. If you read the LCD guidelines from Medicare, this type of system would not qualify as having the orthotic attached to the shoe.
All right. Do you agree that the orthoses should have a deep heel cup with the braces?
Yes, absolutely.
Okay. Let's see. When wearing the wedge I'm sorry. When wearing the wedged brace, how do you manage the contralateral side?
Yeah, great question. Um, so this is always an interesting, but I've learned this from years of managing this. The ideal patient to wear a 30 millimeter heel lift is a woman, because she can wear this system in a, I would sometimes put them in a surgical shoe, and in the contralateral foot they would wear a wedge sandal. You know, they would buy a sandal with a really high wedge or a clog that equilibrated their limb length. But if you want to wear this brace inside of a tennis shoe or an athletic shoe with a 30 millimeter lift, you've got to wear a 30 millimeter lift in the contralateral shoe, and that can be challenging. A 20 millimeter can be tolerable, but 30 millimeter is tough. And for a woman, it's easy, but for a male patient or a woman who wants to wear a lace-up shoe, it can be challenging, but it can be done. There are shoes that have really deep heel counters that can accommodate a 30 millimeter lift.
So this is, I'm going to chime in. We've got a delay, not a delay, but we've got a break in questions coming through. So I'll ask one. For individuals, because the walking boot is kind of the traditional, such a popular and traditional protocol, and really, I think a lot of physicians struggle with making any change to their routine. How would you recommend just making this change in their standard protocols and just kind of biting the bullet into switching over from a walking boot to the AeroSpring?
Yeah, it's a great question. You know, I think one of the reasons it's just logistical. It's easy to stock walking boots in the clinic and dispense them on the spot. The reimbursement for walking boots is really handsome with pretty low overhead. I mean, you can buy them as cheap as $30 and get reimbursed $200. But the other side of it is patients hate the boots and they don't wear them. You know, they wear them less than 50% of the time. They can't drive a car with them. They don't wear them in the house. If you dispense a carbon fiber brace, they will wear them because they walk normal with them. They can unstrap it and drive a car with no limitation. They can walk with total energy return with a carbon fiber brace. They won't get hip pain and low back pain. The downside is you have to order this when the diagnosis is made. This system can be drop shipped to you within a matter of days. So if you temporarily offload them or put them on crutches, or if you're creative, you could put them in a walking boot and then transition them to a carbon fiber brace. But then with Medicare patients, you could get into the same and similar situation with reimbursement, where you would have to justify from a medical standpoint why you ordered a walking boot and now you're putting them in a carbon fiber brace. And I think that'd be a tough challenge to justify it, and you might get that subsequent claim denied. But I think it's worth waiting a few days to get this drop shipped to you. because these patients are going to be immobilized for 12 weeks or more, and they are much more compliant and happy in this system than a walking boot.
I just maybe am not understanding you because you just have to cast for the orthosis, correct? Not for the brace.
Correct.
So if you don't have to cast for the brace, is there a reason why you can't keep an inventory of these in the office?
You could. It seems, most clinicians are hesitant to stock a $400 device,
Mhm.
what a
Yeah.
small, medium, large, left and right. In
Right.
larger clinics, that's not a problem at all. I mean, we stock things that cost even more than that, but that is a sometimes a deal breaker where people would rather just drop ship.
Okay. Okay, we do have another question that came in. Because it takes at least, sometimes, depending on the lab you use, 2 weeks to get a custom orthosis, what would you do in the interim?
Well, it's interesting. The plantar fascia offloading system doesn't use a foot orthosis. It just uses the heel wedges. So you don't have to do the foot orthosis. Number two, no, the Achilles system doesn't use a foot orthosis. The plantar fascia system does use a foot orthosis. About half of the patients who come in with heel pain bad enough that you're going to put them in this system. Obviously, you're not going to put them in this system when they have early onset of plantar heel pain. This is a $1,200 system. You're using this for the patient that comes in that's had a 6 months to a year of heel pain. The chances are they already have a foot orthotic, and that's fine. We just place the heel lift under the foot orthotic, and you've got the system ready to go. You could start with the heel wedges and the brace and wait 2 more weeks for the foot orthotics. It's not going to be a big deal because, like I said, they're going to be in this brace for 12 weeks or more. So you could have the system drop shipped to you while waiting for the foot orthotics.
Okay. What is thought to be the reason that the number of Achilles tendon ruptures are increasing in whichever country it was that you mentioned?
Yeah, they're not only increasing in Scandinavia, but in this country. And boy, I mean, if you're watching the NFL this year, there's been more. I've seen more Achilles tendon ruptures this year than any year I remember. And I'm a pretty avid fan. Um, I believe it's environmental. We know that quinolone antibiotics contributed to this, but we've been, that was discovered almost 20 years ago, and physicians are a lot more careful about prescribing Levaquin, to patients, but we still see it prescribed. But I just wonder if there's other things we're ingesting or doing that's changing our tendon integrity, because it's alarming how frequent we see this compared to 20 and 30 years ago. I think an unhealthy lifestyle we do know that hyperlipidemia, we do know that the metabolic syndrome, which combines diabetes and hyperlipidemia, hypertension, and obesity, does increase the risk of tendinopathy. And so I think we're less healthy now than we were 30 years ago, could be one guess. But when we see this in these high-end football players, NFL players who don't have metabolic syndrome or diabetes, you wonder, I don't know, are they doing other performance enhancing drugs that we don't know about or what? But it is a very noticeable public health concern.
What is the customary time frame for complete pain relief in a Ritchie brace while healing might take 12 weeks?
Well, I have found anecdotally offloading an Achilles injury, even a rupture with this system, the pain relief is almost immediate. It's within days. The trouble is the healing. The healing is at least 12 weeks. So that's the problem. These patients feel really good. I mean, Aaron Rodgers is talking about coming back and playing this season 12 weeks after rupturing his Achilles. I mean, that's unheard of. And one reason he thinks he can play is he doesn't have any pain, which is not unusual.
We did have a comment, pickleball is causing a lot of injuries.
Yeah.
I mean, those quick start and stop movements. Yeah, I can understand. But also, just another comment regarding introducing the AeroSpring into your practice. We know that there are a lot of podiatric physicians that are hesitant to really dispense a lot of AFOs in their practices because of their um, maybe anxiety or regarding casting. And so I wonder, I mean, what are your thoughts on, is this kind of like a good option for physicians who are hesitant to cast because they're not really comfortable doing it and using this system?
Yeah, I think it is. I think it's a lot more user friendly than the Ritchie brace in the sense that it's a prefabricated brace. You do have to be a little careful. It doesn't fit everybody. There's a certain uh, ankle circumference that will be accommodated before they start to rub on this medial upright. But it's actually is a really obese patient that would not be able to fit into this brace. But 90% of patients fit into it without having to go to a custom carbon fiber brace. So I think it's just, I think maybe the casting, but it's just different. It's new. These braces weren't taught in school. I know they weren't taught when I was in school, and I teach at two of the schools, and I don't see carbon fiber AFO bracing being taught to any degree in the biomechanics or sports medicine classes. So
Well, it has to
it's
be a
new.
lot lighter. Is it a much lighter in weight?
Oh, it's probably a third the weight of a walking boot.
Mhm. um, and with with the orthosis, like you said, for the Achilles offloading, you just need the heel lift. But for the plantar fascia offloading system, I assume you can do any sort of casting method, the a scanner, biofoam, or plaster casting for the orthotic itself. Correct?
Correct.
Right. Okay.
And you can use a prefab orthotic. We've
Oh.
had doctors say, look, I have a Medicare patient. I should have brought this out. I have a Medicare patient, doesn't pay for foot orthotics. I know the brace is going to get covered. What do I do? And I say, why don't you order a prefab from your friendly lab? All of the Ritchie Brace lab distributors offer prefabs.
Mhm.
Or just get a power step, off the shelf device. And then you've solved the problem of heel elevation while protecting the arch of the foot, which is something I tried to emphasize in this webinar.
We'll have to take that because Power Step is one of our sponsors, so we'll have to.
It's a great device.
I'll say thanks.
It's a great device.
Um, what is your most efficient or favorite tool for casting?
Oh, I think now I haven't I haven't yet personally used the iPhone, but I liked the iPad scanner with the structure sensor scanner
Mhm.
because when I looked through the phone, I could see the image of what I was scanning. And up until recently, the iPhone app was a reverse. It was like doing FaceTime. You have to hold it up and look through it this way to get the scan. So, but that's changing. The newer technologies, you're able to actually scan through the camera directly like we do when we look at a picture. Um, but I just want to say this. I think scanning is far superior to casting. All of these fears that it's not as accurate and so forth are not founded. There are many studies showing it's exactly as accurate in capturing the anatomy as a plaster cast. But the advantage is you can transmit this scan to your lab right on the spot. You're saving 3 to 5 days of shipping. You're saving shipping costs. And finally, it's a high-tech modality that the patients really buy into. I mean, they love this kind of technology, and you showing them their scan, it's such a cool thing to do, and then show the patient right away a three-dimensional view of their foot and lower leg. I just don't know why you wouldn't do that in every case instead of plaster.
It saves a ton of time in the office as well.
Yes.
Um, and just to mention, if you go to richiebrace.com, in the education section of the website, there is a large amount of videos about casting with Dr. Ritchie. a lot of tips for casting with different methods. So that's always helpful. So those are all the questions that have come through, and we are at 8:15. So I think everyone's ready to take their chamomile and get cozy. So I know you're in California, so you're probably just getting ready to eat dinner.
I am.
The rest of us at the nighttime, we're coming so early. I'm just like, I'm ready for bed. So thank you again so much for everybody who's joined us this evening. Dr. Ritchie, thank you so much. Obviously, we love having you, and get ready for more from Dr. Ritchie with Practice Partner Academy in 2024. We are super excited to release our webinar schedule for the next year. Speaking of our next webinar, same place, same time, a week from today, we are doing a class 4 laser review with Dr. David Zuckerman, who will be going over really any question that you have about class 4 lasers and comparing and contrasting the lasers that are in the market for the lower extremity, whether it be discussing power levels, multifunctionality, warranties, training, support. So David is an expert. He has been using hands-on with lasers for over 20 years. He's the OG of lasers, and we have the OG of AFOs tonight, and we'll have the OG of lasers next week with Practice Partner Academy on the 11th at 8 p.m. Eastern. So we hope to see you there. And until then, have a good week, everybody, and we'll see you again soon. Thanks again, Dr. Ritchie.
Okay. Bye-bye.
Bye-bye.